Good morning, everyone. My name is Maya Luria with TMC for Seniors, and we are in November, and traditionally we usually do things around diabetes. Today is Diabetes Day, so we've got a couple of talks that are coming up. We're going to start with now into the world of diabetic medications, GLP1s. I have Heather Schroder here with me. She is a nurse practitioner with our TMC Clinical Pharmacy. And welcome, Heather. How are you?
Good, thank you.
Good. So I'm going to go ahead. I'm going to put your PowerPoint up. I know you are going to share so much information regarding GLP1s, and this, of course, has been such a hot topic. Do you have an online audience that is joining us today, along with an in-person audience? So if you're watching, please go ahead and leave any questions for Heather in the chat, and we'll get them addressed afterwards. I'll turn it over to you, Heather.
All right, thank you. So I'm Heather Schroder. I work in the inpatient world for diabetes, and I'm gonna kind of get started because I have a ton of information, and I know I'm gonna skirt over a lot of this, but that's kind of why I tried to write most of it down so you can at least reference it. But there are multiple different formulations of this. There's the classic ones like Trulicity, Byetta, Bydureon, Victoza, all of those that are, Ozempic. Then we've got these dual acting ones, and really the only one we have right now is Mounjaro. And then we have ones that are mixed with insulin. So you might see one that's like Zoltrophy or Soliqua. Those have the GLP-1 plus insulin together with them. This is kind of some of the variations in colors and things that they can look like. The only oral agent we have is Rybelsus, which is basically Ozempic in a pill. Everything else is going to be an injectable, and each pen works a little bit differently. So you'll want to just touch base with your pharmacist on how that pen works. This is kind of a quick comparison chart, kind of as far as whether it's injectable pill, what its medication is used for. So obviously when we look at, coverage from insurance companies, weight loss is usually not a covered cause. So you'll want to be careful about what your prescriber is prescribing you. So what do? There's always a piece in medicine that we kind of go, well, we don't know entirely, it just works. But what we do know is that when you take in food, it enhances your insulin secretion. So it's kind of making that connection between when food goes in and gets processed through the intestines and starts to come out to when the pancreas is secreting insulin to help bring that blood sugar down. It also slows your gastric emptying. So instead of that sugar hitting the system and creating a big spike in your blood sugar, it's going to plateau that out a little bit and prolong it so that pancreases that are already functioning at a pretty high level, producing extra insulin to help combat insulin resistance, is going to help kind of have a chance to catch up with that. It's going to kind of slow it down. And by doing that, you're not going to eat as much because you're going to stay fuller longer. And, particularly after eating, you're going to stay fuller for a longer period of time. So we see more of that reduced intake in the post-eating initial one. So you'll eat your breakfast and then you'll have a little less intake after that, just the rest of the day. And that's mostly what patients tell me is they'll say, well, I have breakfast, but then I'm just not hungry for the rest of the day. And that causes problems because you have an increased chance of nausea. And, we also, most of the time, especially in type 2 diabetes, these are, in conjunction with other medications. So you have a higher risk of having low blood sugars if you've got insulin on board or something like that. So sometimes you have to remember to eat on these meds because they can work a little too well. The other thing too that I want to highlight is there's no evidence in humans that you get beta cell regeneration. There's I did a quick Google, and even on some fairly reputable sites, they say it's regenerating beta cells. That's in mice. We're not cutting open humans and dissecting their pancreases and, looking at this stuff. So just know that. Side effects, the main ones that people have are nausea. And there's obviously side effects that we do want, which is weight loss. But there are some people who we don't want that in. You know, if you have somebody who's underweight or just right at that cusp or barely eats anyways, we don't really want these medications on them. And unfortunately, I see that a lot. You know, I see patients come in, they're already underweight, malnourished, and they're put on these medications because they do work, but they're further causing weight loss in somebody who doesn't need it. And Letty has a bunch of other people set up to kind of discuss what happens with all of that. So I'll just kind of briefly touch on that piece as we go. But the big thing that we do see people coming in for is pancreatitis. These medications can induce pancreatitis. So somebody who has a history of pancreatitis or who gets pancreatitis while taking this medication, you're off the class. Don't do it again. It's not a guarantee. It's just some people are more prone to it.
Can you speak a little louder, please?
Yes. Oh, yes. Absolutely, yeah. I was just saying that pancreatitis is a common side effect. You know, it's not super common, but we do see a fair amount of it. But that's in people who have a history of it or who might just be more prone to it. So there's no guarantee. But if you do develop pancreatitis while on this, or if you have a history, we recommend not starting this medication. Or if you're on it, stopping and not restarting another one. You can get both diarrhea and constipation. I have people getting both of those. There's really no rhyme or reason as to what patient would get one or the other. Sometimes it's not problematic for people and sometimes it is. And then again, low blood sugars are usually when used in combination with other medications. So we'll go over that in a second. I'll touch on that in a different slide. Less common stuff are your gallbladder issues. So I tell people just use it and be cautious about it if you're getting abdominal pain, you know, and it's persistent, you know, or if you've got like a giant stone in there that we're just watching, you probably don't take this medication. And intestinal obstruction goes through that whole process of it's going so slow that sometimes things just stop. The other thing is the thyroid C cell tumor. Those are really where those were noticed were in rats when given very high non-therapeutic doses of this over a prolonged period of time. We have not seen them in humans. And these drugs have really been around for a long time. I don't know if anybody knows Victoza. That was around a long time ago. Byetta, Bydureon, those have been around for a really long time. And so we've been using these drugs. They just haven't had quite the fad that they've had now. And some of that was because the dosing of those was more frequent. So these once a week dosing ones are much more favorable. And they also had a few more side effects. So mostly I tell people that, but really it's not something that I have seen in patients. There's also some other genetic neoplasms that are like multiple endocrine neoplasm stuff that we honestly, you would know if you had that and nobody would start you on that med. And dehydration can cause kidney issues because people just don't drink or eat anything. You know, they just don't put anything in, or if they're so nauseated. And remember, these are once a week drugs. So if you're going to get nausea, you're going to get it for a week. So you got to be careful with that piece of it. I've seen some people end up in the hospital just because they can't take in anything. So, because they're very sensitive. So it's important to start at the bottom and work up with these meds. So again, contraindications, and it's also not approved for type 1 diabetes. And then, so how is it going to help you? So it does multiple things. Again, it's kind of what came first on this one, the chicken or the egg. So as we're lowering blood sugars, we're losing weight, stuff like that, we're going to have improvement in things like heart disease and, you know, and blood sugars and, you know, so your A1C is going to go down and you're going to have better outcomes in general. So this kind of take it with a grain of salt a little bit. Because they haven't had the trial data to do long-term studies either. And really the main one out there was Ozempic, kind of paving the way on some of these studies. And then some of the other ones kind of came in after it and didn't have to have as much robust data. And when Ozempic did this, they did do this on high risk patients. So their studies looked really good because they took patients who were really, really sick and gave them a lot more improvement. So keep that in mind. You can always go to clinicaltrials.gov to kind of see the data on it, but it's all how it's kind of spun out when you get kind of the summary. And so just be a scrutinizing consumer. So the ones that have risk for, or reduced atherosclerotic risk is going to be Victoza, Ozempic, Trulicity. Mounjaro, it didn't have any improved data, but that being said, it's essentially the same type of medication with one extra little component to it. So it's kind of inferred, we'll put it that way. So, but there's no great trial data on it yet, and it's our newest one out there. Rybelsus, the oral Ozempic, does not have any risk improvement. There's really no, there was no seen data in that, but I will say that it wasn't necessarily studied all that much. The focus was on the injectable one. And then again, this is just kind of hones in on that semaglutide trial, and that it only lasted 2 years, and they were really like their endpoints were death from cardiovascular, non-fatal heart attack, non-fatal stroke. So they weren't really looking at weight loss. They weren't really they were just looking for this major impact, and that's what they're rolling with. And you guys can kind of read that stuff. I won't perseverate, but you do have an improved, outcome in people who are at risk for stroke. Because again, you're improving blood sugars and losing weight, and that's helping with your blood pressure. And, there's kind of these downstream effects. Heart failure, again, there was no change in heart failure, but interestingly enough, I just have to point this out, they had an improved 6-minute walk test. I'm like, well, of course, if you have weight loss, you're going to improve your walk test. You're going to improve the heart's, ability to pump against this increased surface area. So again, some of these things just it's kind of like which is really leading to this. So weight, I'm going to stop on weight for a few slides. So evidence doesn't support that your resting metabolic rate is entirely due to weight gain. So intake and exercise are your most significant factors. And when you lose weight, you lose both adipose tissue, which is your fatty tissue, but you also lose muscle too. And we'll talk about kind of trying to maintain that, because your muscle is your metabolism. And so if you're losing vast amounts of muscle, you're losing your metabolism a bit there. So a lot of times with these drugs, people are on them and they usually stay on them, but people who want off of them will sometimes regain that weight because they just lost their muscle mass. And so now they don't have that increased metabolism. Also too, if they haven't, had good lifestyle changes in the meantime. But basically, your hunger hormones actually increase when you lose weight because your body is always trying to get you back to that highest set point. So you're actually feeling hungrier. And it also ramps down the hormone that makes you feel like, okay, I'm full. I don't need to eat anymore because it wants to get back up to that. So your resting metabolic rate actually starts to decrease with weight loss. So again, you need to make sure that you're maintaining that muscle mass and adding in exercise and strength training and all that stuff. So there's many ways in which we have to adjust our weight. There's nutrition and the physical activity, but there's also behavior. So I wrote on here kind of, choose to park at the back of the lot and walk, that just those little behavior changes, if you can, if you're not limited, do those things. Take the stairs if you can versus an elevator. Environment, reducing your stress, making sure that, if you're going to be purchasing foods, you're trying to do, kind of more healthier food choices as you can. Obviously, we're all limited financially and what's available and time of year, all that kind of stuff. And then hormones. Medications will affect your hormones, but also bariatric surgery does that. So and honestly, there's medications that promote weight gain, and there's a lot that promote weight gain out there. So it's oftentimes a very competing environment for weight. It's not just a simple thing, or else we'd have this thing licked, which we don't. So again, complex system, multiple hormones, and basically the weight hormones they promote weight gain, and they help you kind of put on more adipose tissue for the long run when you're not eating, for when you're in a fasting and you need to have stores to break down. And then there's 3 areas you get hormones from. You get it from your brain, from your actual intestines. We call those the gut hormones. And then your adipose tissue actually has hormones effects on it as well. These are all the different kind of hormones. I won't perseverate on that, but lots of them. So again, gut hormones are going to affect how hungry you are and how you digest, and how that is equating to blood sugar lowering through the pancreas. So kind of a multi-factor. The GLP1, again, I just kind of restated this multiple different ways, but you stay fuller longer, you eat less, you feel more satisfied, and it changes how your body can use those nutrients when they hit the system. So to help with weight loss, again, that resistance training, and I won't perseverate on this because you got more talks coming up on that, but it's that lean muscle. And so you want to increase your protein, but you also need to increase that exercise. And it's also good for your bones. It's good for, all sorts of different things to kind of stay active. So a body in movement stays in movement. So again, with glucose control, we have, our blood sugars being better able to be managed by our pancreas with these medications. We're also decreasing the overall intake, so there's less volume of nutrients and sugars coming into the system. And the one thing that this does have is it doesn't usually cause low blood sugars. But again, if it's with other medications, you can have more risk of low blood sugars. And then the GLP-1 that has like your Mounjaro, those ones who have like the GIP on them, that one actually has a little more improvement in preventing low blood sugars because it actually helps support glucose release in a fasting state. So, a lot of times we don't see low blood sugars with those medications unless somebody just, again, stops eating altogether and they have no nutritional reserves. We're going to see that. So somebody who's severely underweight on one of these are going to have more risk of low blood sugars. And then, let's see. So the GLPs and the GIPs, they're additive, and we secrete both of those. And I will say this, that there are those people who get on these drugs and they lose a ton of weight. And there's people who get on these drugs and they don't lose hardly any weight. You produce GLP-1 in your body. If you have a sufficient production of it, you're not going to see as much weight loss. You might still see blood sugar improvement. You might see some insulin resistance improvement. So it doesn't mean that it's not doing things for your blood sugar, but you might not notice the weight loss. If you're not losing a ton of weight, it doesn't mean that it's not working, unless that's the sole reason that you're on it, but switching to a different one isn't necessarily going to make a huge difference with weight loss if you adequately produce GLP-1s. So that's going to be more like you need to be focusing on your diet and your exercise more so than just on that medication to try to help. It's really, we don't know all the reasons that people develop diabetes, but we do know that GLP-1 deficiency is a risk factor in developing type 2 diabetes. So a lot of times that's why we saw weight loss in these drugs. They weren't originally designed for weight loss. They were designed for blood sugar control, but we saw the side effect of weight loss with them. And then they've been manufactured more into a, a weight loss category after the fact. So, and again, GIP, we don't know entirely. There's some help. We just don't know entirely what it does exactly. So is it worth the hype? Honestly, it's really your choice. All we can do is give you information, but cost can be a limiting factor, along with things like, access to the drug with drug shortages, and people don't like to inject themselves, also side effects, stuff like that. This is kind of a quick, who's appropriate for it. So basically people who have type 2, not type 1 diabetes, if you've got heart disease risk, if your A1C is not at goal, if you're hoping to get some weight loss out of it. Chronic kidney disease, that one it can be beneficial, again, by helping to control blood sugars, but it can be problematic if you're getting super dehydrated and causing worsening kidney function. There are a couple medications, the older ones, your Victoza and your Byetta Bydureon. Well, actually, no, Victoza is okay, but Byetta Bydureon, that one, if you have kidney issues, just don't take that one. The other ones are all okay. And then, so again, people who are not appropriate, again, these are pretty self-explanatory. That gastroparesis is just people who have slow-moving guts in general just tend to have more issues then, because we're making it slower. Drug shortages, basically, I'll let you guys read this, but basically people were doing a lot of manufacturing, particularly of Ozempic, black market stuff, and there's no FDA regulations on that. And so if you're going through a compounding pharmacy, you want to make sure it's reputable, you want to make sure that they're able to stand behind their drug, but there's no exact formulations that every different compounding pharmacy is following, so you might see some variations. Honestly, if you can obtain it over the counter without needing a prescription, I would not do it. Who knows where that came from. And there's also some dosing differences. So when you're using it in the manner of weight loss through a compounding medication, a compounding pharmacy, the dosage is not the same as when you're using it from a prescription from the FDA. Oh, sorry, I thought it was a question, sorry. And so these are just kind of that there are switching overdoses, because there's a lot of time that we have to switch somebody from one formulary drug to another formulary drug based on availability. So we have some guidelines out there, so it's not just all guesswork. So again, things that your provider should be watching, honestly, they're going to be watching out for those side effects. They're going to be looking at your weight, your blood sugars, labs, with the thyroid risk, making sure that they're palpating your thyroid every year, making sure they're checking your TSH. The retinopathy, that one, I kind of roll my eyes on that one, because any medication that's going to lower your blood sugar in a rapid manner potentially can cause this worsening retinopathy that can happen transiently, and it usually resolves. So it was just something that as they did these studies, they had to put it out there, and so then it became a big warning on there, along with suicide was one that's come up more recently. And that one, honestly, it doesn't necessarily induce suicidal thoughts, but it's just that it's happened in conjunction with people that are taking the medication, so they have to report it. But again, that's such a multifactorial issue that it's hard to make that connection between, the medication. Again, labs, how's your vision, that type of stuff. Okay, so you decide to do it. Cost. You can see the cost is stupid. It's crazy. It's expensive. And there's a lot of things so you can get in a 1 month, a 2 month, or a 3 month. There's mail order pharmacies. There's physical pharmacies here. All of those change what the cost of the medication is. And it's all variable based on your plan. So you're going to need to kind of look at your plan. This is something I just kind of did a quick on Medicare.gov. I just went to a plan D and kind of looking at several different pharmacies. And you can see here that each pharmacy, and you can do this with your own plan, but you can see the actual cost of these medications. But I'll point out that, like let's look at Mounjaro. That if you order that one from a mail order pharmacy, it's zero, no copay. So some of these things, you might just need to switch to a different pharmacy, like use your mail order for that. And again, this is just more of a breakdown month by month, but they can be pretty pricey. And that's just a sample. There's a ton of information on this discount billing card issues, that type of stuff. So honestly, pharmacies are super busy. Sometimes it's not necessarily that it doesn't cover the medication. It might just not cover that medication. It might cover Victoza, or you might have to do a step up where they want you to start with the older meds and move up to the newer meds. You can't just start at the newest med. And when you use these discount coupons, they're kind of tricky. So just talk to a pharmacist. It might need to be a 1 month, a 2 month, or a 3 month prescription. A lot of times on these discount coupons, it'll say like $25 for a 3 month supply. So that's great. But if it's not available, if you can't, like let's just take Trulicity, for example, very hard to get that in. We're only getting what is sent to us. And so there's no guarantee day to day. So the pharmacy can't give more than 1 month at a time. And you're using a coupon card, you're going to pay that copay every time. So instead of $25 for, 3 months, it's going to be $25 each month that you go pick it up. Still better than $600, a month, but just know that. And then again, you can override this, and because some insurances stipulate you have to get a 3 month supply, you can override that in medication shortages. And that's kind of generally a rule of thumb with most medication shortages. And then some insurances exclude the use of coupon cards. So just, be careful with what you're trying to use. Government insurances like TRICARE, Medicare, if you have prescription coverage in those, it doesn't count. But if you have commercial coverage for your prescriptions, you can use the discount card. So even if you have Medicare A and B, but your prescription coverage is commercial, you can use a discount card. Now, and pharmacies again are super busy. So you're going to want to, they just don't always look into this stuff. Sometimes they just need to push through, like it's a soft stop. It's not really something that's going to be truly limiting, but they just haven't had time to read it. So it's at your house. Now what do you do? This is storage. There's a ton of information on here because every med is stored slightly differently. Like, does it need to stay in the fridge? Like Rybelsus needs to, that's the oral one. You think, oh great, whatever. No, it has to stay in its bottle. It can't go to a different bottle. It has to be in that bottle. It has to be taken 30 minutes with less than 4 ounces of water on an empty stomach before you take anything else. I mean, some of them can be a pain in the butt. So just kind of, know that. And administration for the injections, it's anywhere where you've kind of got some soft tissue, but most people will use kind of the abdomen and thighs just for ease. And you just want to rotate because these injections are meant to stay there and slowly absorb for a week. So you don't want to keep going in the same spot. You're going to get erratic absorption. If you need help with those, pharmacy can usually talk it over. Your provider can, as far as each way that the pens are actually, administered is slightly different. So like Trulicity, that one has like a single pen and you don't have to prime it. You just kind of inject and you're done. Like Ozempic has multiple dosings. Like you can have a 0.25 dose or you can have a 0.5 dose on the same pen. And it has multiple doses in that pen, whereas Trulicity doesn't. It's just the one pen and you're done for that week, and so those are all little nuances and you just have to look at the instructions. There's online videos and your pharmacist. And then those are my references. And again, this is so true. If you're pre-diabetic, I can't help you. You either eat less or more sugar, because we just get these people that are stuck in the middle. So thought it was very fitting for everything. But all right, I went through that super quick. I'm sorry. Any questions?
Can the laboratory more in labs or whatever?
They can, but it's not necessarily, it's super expensive and it doesn't necessarily say whether or not it's working to capacity. So-
Heather, I'm sorry, can you repeat the question so that everyone online can hear? I couldn't hear the question, so.
Oh yeah, it was whether GLP1s can be measured in a lab. Yeah, and I just said that it is possible, but it's very expensive, typically not covered, and it's no guarantee as to whether your level is actually effective for you.
Okay. I do have a couple of questions that came in online that I wanted to ask. One is, do we know what the long-term effects of, for instance, Ozempic for people who have used it that do not have diabetes?
Yeah. So no, because we don't have long-term clinical data on those. I will say though that a lot of people who stop the medications who've lost weight on it do regain. But again, it's hard because are they putting in the lifestyle changes? Are they, creating that muscle mass to help keep that metabolism up? Or are they just just kind of hoping that the drug is going to keep them, not eating as much. So.
Okay. And I was going to ask that as well about if somebody was to go off it. Is the medication designed that you would stay on it all the time, or what are we seeing? I mean, I know that the GLP1s are a big trend right now, and everybody seems to be, there's lots of folks that are on it, but are they supposed to be on that long term? What does that really look like?
So what I will say is that, again, we don't have, great clinical data on it. But for the people who've been on them for 2, 3, 4 years, we're showing that it's fine, that there's no bad side effect because we're not giving you something that your body doesn't already naturally produce. We're just giving you more of it. And so unless there's some bad side effect that would limit you, it's fine to probably keep going on them. But again, there's going to be data that's going to pop out 20 years from now. We're going to be like, oh, that was a bad idea. Sorry, everybody, because we just don't know.
And it's also a large cost, right? I mean, as you were sharing. Somebody was asking about, they couldn't quite read the slide on the storage of Ozempic. Is it always refrigerated?
Yeah, usually. Once it's out, it's usually good for 28 days. They did, I believe, change because when they moved from a 1.5 syringe to the 3, I think they did make it like a 56-day because there's more doses in it. But yeah, it's for the most part refrigerated.
Okay. And are there any common drug interactions that you're aware of with any of the GLP1s? So should somebody not be on something else when they're on, one of these drugs?
Yeah, for the most part, no. They, because unless you're on Rybelsus, because that's oral, so, obviously meds that go in are either activated or deactivated when they hit your system. And so it's competing for proteins with other meds that you're taking. And so that has a potential to have some side effects and interactions, but the injection one isn't really competing with anything because it's just being absorbed. And then for the most part, the biggest one is anything that's going to cause your blood sugar to be low or to mask side effects of a low blood sugar, like your beta blocker, stuff like that, that just you get lower before you notice it. So not directly.
Okay. And then my last question before I turn it back over to see if there's any more in person is, do you oftentimes have to try multiple medications to find one that works best for you as far as the GLP-1 may be concerned?
Yeah, I mean, and again, it depends on what you're trying to use it for. A lot of times I have patients who, for blood sugar control, one's not working, and so we'll just we get it to the max dose, and then we'll go to the next one up. But honestly, I don't see a lot of difference on like the Trulicity versus Ozempic ones. Where I see a bigger difference is when we move to like the Mounjaro, where we get the GIP one, factor that helps out there. Again, what is that? We don't really know. So it just helps better. So I don't see a ton of that. I will say that adherence is a big issue because one, weekly injections for some are great, but some people forget. And then availability is so sketchy, and then insurance plans change what's covered. And honestly, like Victoza is once a day. So sometimes people who have problems with daily meds, don't do well with that. So they can be problematic from that standpoint.
That's a good point too. And also, you mentioned like insurance, because if insurance changes what they will cover, that might also, be an issue for you too.
Yep.
Yes, great. I'm going to turn it back over to you, and then I know Letty is going to come up and introduce about building muscle mass. So why don't you can wrap up with any questions that you have in the room.
Oh, one more question over here.
Can you address the exercise part? How much aerobic, how much muscle building? Is it better to do it in the morning, or does it matter?
Dr. Khan is gonna talk about that, so.
Oh, okay.
The question was as far as what is the best way to build that muscle mass, and that's coming.
Oh, okay.
Yeah.
That 1.5%, it caught my attention, but if that means like if you have 6, that your target 7.5 is where you think about going into this.
Yep. And the ADA has moved this into more of a frontline medication too. It used to be kind of second line, like they wanted you to try metformin, or some other oral agent first. Now they've moved that there. So even sometimes if people are at like 7.5 or 8, if your insurance will cover it, they can start on these GLP1s to kind of get that A1C down. So yep. Yeah.
Do you see, would you see us individually?
Oh.
Are you available for individual consultation?
So the question was, am I available for individual consultation? And unfortunately, I'm not. I only work inpatient, but I can certainly answer questions. So I'm happy to, hang around and answer questions if you need, or Letty can get you in touch with me. Yeah. All right, I'll get out of the way. Thank you.
So Heather, just one quick question on that would the outpatient pharmacy, the outpatient TMC pharmacy be able to do, would they have any of that information that would be helpful?
Yeah, they definitely do, because they will do some medication education stuff through there. And, this is my plug for the outpatient pharmacy, is those pharmacists and pharm techs are fantastic at finding you the best deal. Whereas sometimes those bigger pharmacies are just, their volume is so much higher that, our pharmacy goes above and beyond to work with coupons and stuff. They really do. They're my saving grace on discharges, I'll put it that way.
Thank you.
All right, thank you. Thank you guys so much, I appreciate it.
Thank you.
Hi.
Good morning, I'm Leticia Martinez. I am the coordinator of the outpatient diabetes program. And for some of your question, depending it is, you just can be referred to the outpatient diabetes program. I am a board certified diabetes educator. So I'm going to introduce Dr. Combe. And actually, you probably want to say more. Do you want to move here and just tell us a little bit who you are? And then
Yes,
we'll
I
let you
will.
talk. She's going to be one of the side effects or problems with these medications is the loss of muscle mass when you're losing weight, especially big amounts. So, she mentioned already the importance of building the muscle and keeping the muscle. And that's what Dr. Combe is going to work.
Heather, could you get my phone out of my purse, because I like to have some music when we do some
Okay.
exercise. Okay, my name is Dr. Jacqueline McComb, or they call me Jacqueline or Jack or Dr. McComb, I suppose. But I was a professor for 35 years at Texas Tech University in exercise physiology. And I also worked at Covenant Medical Center teaching fitness classes. My husband used to say, "Are you going to flip hamburgers again?" I said, "I like to flip hamburgers, honey." And so exercise is so important. And I've been retired for about 3 years, and I work at Skyline Country Club teaching chair aerobics and being a personal trainer. It's more I've worked all my life, and retirement wasn't exactly easy for me. I really like to interact with people. I taught about exercise prescription for different populations, and if we can, I'll put my card on the table. And I do have a web page that has exercise prescriptions for clinical populations. I'm certified with the American College of Sports Medicine and Exercise Medicine, clinical program director, clinical exercise physiologist, and exercise test technologist. So I have a lot of certifications because I like to learn, and Ananda Yoga and American Council of Exercise. So what I'd like to do today is, first of all, talk about the exercise prescription. I taught exercise testing and guidelines, and we teach students all of these fancy formulas because it's fun, these equations. And don't have these notes in your handout. We will go through some of the exercises, but it's better just to listen. And you might want to write down my webpage, which is www.Jacqueline, my name, Jacalyn, Jacqueline's the way my mom spelled it, Jacalyn, medicine, medicine, JacquelineMedicine.com. Now, I believe exercise is medicine. It changes the way your body utilizes fuel. And I can go through all the physiology, but that's not what I'm here for. I'm here to encourage you to exercise. And the exercise prescription for diabetes, I do have it on my webpage under clinical populations, but it's pretty easy. I'm not going to give you anything fancy. Let's start. It's 3 to 5 days a week walking, either vigorous or moderate. I'm going to tell you to walk 5 days a week at 30 minutes with a friend. And we're going to talk about walking. There are specific ways to walk to prevent osteoporosis. There's this little book, it was about $125 used, Walk Tall. I don't know if you've ever heard of it, by physical therapist Sarah Meeks. And these are very simple exercises, and we're going to talk about walking and how to walk in just a minute. So walking, you should do that 5 days a week, 30 minutes with a friend. You can walk in your chair. I'm going to take you through an exercise. I hope I have time a little bit more than just the end of the 30 minutes because we started about 10 minutes late or 12 minutes late. Okay, so walking. The other thing that is important is muscle building. Even walking, you're building muscle. But muscle building, what do they say? 2 days a week, minimally, or 3 days a week. And how many repetitions? 15 repetitions for exercise. How many sets? 3 sets. Can you do that? Maybe, maybe not. Will you do it if you don't like it? No. So it's better to do 5 and stop and be ready to go again the other day. So do something. It's better than nothing. And then flexibility exercises, 3 to 5 days a week. So I'm old-fashioned. I'm like Jackie Sorensen. And we always use the guidelines for warm-up, 5 to 10 minutes. Don't write this down. 5 to 10 minutes. Conditioning, 20 to 60 minutes. Cool down. 5 minutes. Stretching, 5 to 10 minutes. So I'm going to take you through a mini exercise session. However, I suggest 30 minutes. And what should your heart rate be? Well, we have all these heart rate reserve formulas. We have MET formulas. We have max heart rate formulas. Does that mean we have max VO2? Most people go, what's VO2? Even my students didn't know what it was. But so we use something called an RPE scale, and it's recommended for diabetes. I'm pre-diabetic. And my students, I'd say, well, what really causes, or what is one example that shows that you may have pre-diabetes? I say, number 1 is genetics. Number 2 is genetics. And number 3 is genetics. So if your parents were diabetic, you may be, no matter what your lifestyle is, or pre-diabetic. You can manage it, but you know, the genes that God gave you, you have to put on. Okay, so RPE scale. This is true for walking and for weightlifting. There's a book that I like, it's Smart Women Stay Strong, and it was written by an MD, and she used RPE. And she suggested that when you use weights, it should be hard or very hard. I suggest it should be somewhat difficult or difficult. Because again, if it is painful, you're going to find some reason not to do it the next day. It's got to be fun. It's got to be enjoyable. Okay, posture. I cannot emphasize the importance of posture. We say, oh, my leg hurts. Well, everything goes through the spinal cord, right? And so if you have incorrect posture, you may have sciatic nerve function, many different issues. So we're going to talk about posture too. When should you exercise? When should you exercise? Probably earlier in the morning, not at a time of high insulin activity. You want to, your exercise guidelines, it's very important to monitor your blood glucose before and after. It should be 90 to 250. If it's around 350 with or without ketones, you shouldn't exercise. So you can use blood pressure. There's a lot of indicators of when to exercise, but the most important is probably your blood sugar levels. Okay, when you're going to exercise, you want to give if you take insulin in your abdominal area, not in a working muscle. Let's see. Okay, what I'd like to do now is have you get up. I'm going to take my shoes off, and we're going to exercise. Now, if anything, on a scale, we also have a pain level of 1 to 10. If anything is a 3, you can continue a little bit. On 1 to 10, you can continue for a little bit, but you want to back off if it gets to be higher than a 3. Okay, I'm going to put some music on. I don't know if I'll be able to get in here. And we're going to start with, I'll just use nice, easy music. But we'll do 70s both. Okay. I don't know if it's going to work in here or not. Playback error, so I guess it's not going to work. Okay, so let's everyone inhale, great big inhale. And exhale. Come on, inhale. Oh, some people aren't inhaling big. Exhale, let's go this way. Inhale. And exhale. Hail to the chief, huh? Inhale. And exhale. Now, I'm going to start with posture, and then you sit back down, and we're going to do our exercises in the chair. But let's just start with your ankles, up and down. Now, it's really important that you look at the bottom of your shoes, and you see, how are they worn? Do you have stand out? Do you stand in? Your weight should be a big toe, little toe, and heel. Okay, so some of you may know if you have orthotics in your shoe, but you want to make sure that you are walking with your feet straight, not turned out, not turned in. Okay, your step should be heel toe when you're walking. So we can't really walk, but let's do heel toe, heel toe. Now I'm going to take you to your quads. I want you to contract. Tighten your quads and release. Tighten. Now that causes your kneecap to come up and down and helps get your knees in alignment. Everything starts at the feet. If you're walking like this, you're going to have pain because things aren't going up their normal pathways. This is important. And men don't know how to do this, women do. But you're going to pour water into your belly button. So your pelvic area is critical. It connects your upper body and your lower body. And this is where we start having issues with posture, osteoporosis when walking. So what I want you to do is I want you to stick your rear end out. Now I want you to tuck it. Now I want you to stick it out. Tuck it. Out, in. Out, in. Okay, now I want you to pull your tummy in, bend your knees, put your hands down. Now I want you to stick your rear end up in the air. Now I want you to tuck your tail like a scared little doggy. Up in the air, Now tuck and stand back up. Could you feel anything in your lower back when we did that? Okay, so if you notice sometimes people as they age start walking with their hips forward. They do that because that relieves pain that they may have. If you have fusion in your L3, L4, L5, it's recommended that you keep your pelvic area forward. This is called a posterior pelvic tilt. So this is what we say though is keep your tummy pulled in, keep your buttocks tight. So when you're walking, you're not walking like this. Your tummy's in, buttocks are tight, and you're walking heel toes straight ahead through your hip. If I have an anterior pelvic tilt, so it could cause osteoporosis because I'm not walking through my hips, I'm walking in front. Okay, you can almost sit down. So doesn't that feel good? Okay, up, down, up, down. Okay, your shoulders, we say you want to have a long neck. Okay, so feel pretty comfortable? Okay, you can sit down, please. So let's start now. I'm going to do, I have, Letitia, will I have extra time or will it just stop at 9:30? Because we started a little late. I don't know, but I'll do whatever it is. A little bit. Okay, we're going to. Oh, okay. Well, that's good, baby. We didn't get a break, so. And I wanted to use music, but that's okay. Okay, let's start with patting your head. I used to make my students do this before they had a test because to get more blood. And there's really a lot of truth in this. And your neck. Anyone ever had neck ache, shoulder aches? Okay, it feels so good. We store our tension in our shoulders. Now let's go ahead. When I do this, I can feel nerves going down my spine. I don't know about you. I can feel in my knees. Anybody else? And otherwise. So your spine is so important. Now we don't want big movements. We want to go forward, middle, back. Pecs, trapezius. So you're only moving this. Forward, middle, back. Now I have just worn my body out. So this arm doesn't work. But I want you to put both your arms up. Well, you can see how high my shoulder is. I've had 3 shoulder surgeries, 7 finger surgeries. Okay, so up and down. All I want you to do is you're working this muscle. Up, down, up. Okay, now let's take your hands down and go up, press down. So we have sternocleidomastoid, levator scapula right here, and we want to keep it pressed down. Our shoulder, our glenoid cavity is the most mobile of all joints. And if it's not sitting right in that socket, we'll have issues. So we want to have shoulders pulled back and down. Okay, let's keep on going to the side. Here we go. Just little. You can do this when you're watching television, right? Or maybe during football, you can stand up and root for your team and sit back down and out. And really stretch. Okay, I want you to sit kind of on the edge of your chair. Sit on the edge of your chair and round your back. And then arch, look up. Exhale, round, arch, look up. Round, arch, look up. Okay, good. So breath. I've talked about breath at the beginning. But whenever we inhale and exhale, we don't get all of our dead air out. So there's some air in our dead spaces, in our throat, that is mixed with carbon dioxide. So it's important to exhale as much air as you can. And in yoga, we exhale twice as long as we inhale. So because you want to get that dead air out, fresh air in. So let's just inhale with a count. So inhale, 1, 2, 3, 4. Let's hold, 2, 3. Exhale, 1, 2, 3, 4, 5, 6, 7, 8. We're going to try that again, but you want to use your tummy to push it out. And if you have pulmonary disease, you can use pursed lips. Okay, let's do it again. Inhale. 1, 2, 3, 4. Hold. 2, 3. Exhale. Push it out. 2, 3, 4, 5, 6, 7, 8. Okay, good. So when you're walking, big breath, really, I don't know if you can think of all that. Okay, let's go on down to our hips. So iliopsoas, this is a muscle that can be problematic because it's tight and it can cause an anterior pelvic tilt. So in and out. Okay, good. Now let's go both in, out. Okay, and how about this? Okay. Yeah. Okay, and let's kick your feet. Kick. Okay, and shake your hands. Okay, and fingers. We forget about how important our fingers are. No one in here has any arthritis, right? And we want to keep moving. Okay, feet are real important. And ankles, yeah. And, think about your poor little feet. They hold you up all day. And do you ever give them any attention? Balance. Yeah, balance. And, I was a professional water skier at Cypress Gardens, skied backwards one leg. I cannot balance at all anymore. Just lost it. Okay, let's talk about now. That's your warm up. And let's talk about, okay, first thing, you want to wear a hat when you walk right outside. You want to protect your skin. Now, weights can be used, and I had 2 cans of food in here, but my husband didn't want me to take that food, so he got some difference, and I don't know where it is right now, but I think I had some expensive tomatoes, and he wanted me to take beans. But so you can use cans of food. You don't have to use this. You don't have to use any weights. And you can use this for your legs when we stand up and down. Other things, you don't really have to go out and buy expensive equipment, but stretchy bands. If you don't have a stretchy band, you can use your hose. You can put them here and yeah. So it works.
Yes.
Also, yoga belts. This is from a house coat I have. You can just tie out there and try to stretch your legs. So there's all kinds of things you can use. A little bit more sophisticated with handles, but how often do you think you're going to use this? Only thing we had a gym in our house. The only thing I did was dust it. So you need people. You need people. Yoga blocks. So there's all kinds of things. If you want to do someone have a balance, you can put it on the side and use it for balance. These are great. Now this is a ball that I found in the street. I didn't wash it, but it is great for pelvic tilts. Lying down on your back, and it just feels so good going around in a circle. Okay, now let's begin. We're going to start with just a little bit more of conditioning. So you're in place. Good. Okay, good. Just walk. Arms. Okay, now let's arms. We're not going to go real long because you guys are not really dressed for it. Up, up, up. Great. Up, up. Okay, now let's go ahead and start making it a little bit harder. So stand up. You can. You don't have to. But don't sit down. Just wait right there. Okay, back up. And wait right there. This is where it's hard for people to get up off of the chair. They don't have this strength. Up and down. Okay, let's go. Let's sit back down again, and let's get a little bit more aerobic conditioning. What else can you do to get your heart rate up while we're in the chair? Let's kick, kick, kick. Now you can start adding a touch. Good. You guys are great. Okay. And then you get a little tired of doing that, right? So that's both feet out and in, out and in, out, in. Faster, 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 faster. Go, go, go. And let's shake everything. Okay, it feels good, doesn't it? It feels good. Now let's start. Letitia gave us some handouts, and I gave you some handouts, but let's just kind of go through a few of these exercises. Now, one other thing, in the traditional format, we do the aerobics first, and then we do the resistance training second. But for diabetes, it's recommended that you do the resistance training first, and then the aerobics or the aerobic conditioning next. So probably before you walk, you could sit in your chair at home. Better to go somewhere where they have exercise because you're going to do it. At home, it's a little harder, isn't it, to make yourself do it. And we really do need each other. So the squat, we already did the squat, but this is, Letitia handed this out, and this says squat right here. Now, something else that's important are Kegel exercises, which means you squeeze your pelvic floor muscles. So we're going to kind of add that with the squat. It's like you're trying to go to the bathroom and you can't go and you're really pushing, or you're going to the bathroom and someone rings the doorbell and you need to stop. So we want to just squeeze your buttocks, your pelvic floor muscles. Okay, so let's just do a squat. And we won't go too long. So you've already, so everyone stand up, please. Now, you want to be thinking about posture. Tummy in and squat. Weight on your heels. Okay, you can put your arms out here. Now, I want you to do a Kegel exercise. Squeeze your buttocks, squeeze your pelvic floor. Okay, and then stand back up. And let's do it again. We won't do it, watch it like 3 to 5 times. Squeeze pelvic floor muscles about 5 to 6 seconds and back up. We're going to do it 5 times. And squat. Good. And back up. Last time. Squat and squeeze your pelvic floor. Okay, good. Okay, and you can sit down. So you can make it harder by just holding a weight on your legs when you go down. There's or 2 cans of beans, whatever. Okay. I try to work all the different muscles, and I won't go forever here. But we did squat. This is your hip stabilizers. These are your hip stabilizers, your gluteus maximus. Balance is all about strength. So you want to increase, or just while you're sitting there, everybody squeeze your buttocks and release. That's effective. Not as effective as moving, but it is effective. Okay, you don't have a ball, but you can at least put. So let's say that we want to increase our adductors inside of our legs. Just press your knees together. Press and release. Press your knees together. You feel that? Inner thigh. Okay, good. Now let's say we don't have a band to tie around. We don't have any bands to tie around. We put our hands here and press open. Press. Now we worked our buttocks. If you do 15 reps, we worked our inner thighs. We worked our outer thighs. Okay, so I like to start at the bottom and work up. Let's just do abdominals. I want you to hold your hands underneath your chair. Oh, and can you lift your knees up? It's hard. Now, can you lift both knees up? Aha! Now 1, 2, both. Woo! And 1, 2, and both. Okay, now let's just do one more of those. Lift both knees up and just hold it for a little bit, and then back down. Lift both knees up, and can you kick one foot out with the knee lift, and then the other one? So you can continually keep adding on. Okay, let's do shoulders and shoulders. These circles are so important. And when we're walking, we're using our tiny muscles, which are slow twitch muscles. And when we do big exercise with machines, we bypass those muscles. And so it is important just to do little bitty exercises. Now, take right down here. So we're working tendons and ligaments that are real important. Okay, good, great. Now, up a little bit higher. I can't do it because I thought I was Superwoman, but I wasn't. Okay, now, we've done probably enough. Some of the other ones that are on the handout are like let's just take that. But this, and you can use the back of your chair and just, push up. And if you're really strong, you can use this and push up. And I'm not really strong, but you can do all kinds of things. Let's start going to the stretching part. So we've done warm up, and the warm up was really, let's do this. just hit like peripheral vascular disease. And we don't think about it. And cool. Get that blood going back to your heart. Help it. Ugly. Good. We pay someone a lot of money to do massage when we can. Your husband was glad to do it, right? Or your wife? Only before marriage. After marriage, pay for it, honey. Okay, and here we go. At least that's the way it works in my family. And see, and I can't, and it's really hard for someone whose profession is exercise to not be able to exercise. Okay, or not be able to move your arm. Okay, pull it back. Good, so I see some people that have some issues. I do, I can't do it, but aging is all about humility, isn't it? It's not easy. Okay, good. And let's come back here, and I think we have to go for the next person and stretch. Okay, this is the last thing. Okay, this is a great stretch. Can you cross your foot? And now go over. It feels so good. This is for your piriformis muscle. And then other one. And if you have sciatic pain, this is a good thing to do. Okay. Thank you very much. Wow. Oh, yeah.
Thanks so much for being here. We will be back at 11 a.m. for our next talk, which is on fiber, a powerful tool for blood sugar stability. So 11 a.m. this morning. We'll see you soon. Thank you.